Well, if you recall, the first consensus document was published in 2007. The next was in 2012, and 5 years has passed. So now it's 2017. So it's mainly because of 5 years being elapsed. And the field, as you know, continues to evolve so rapidly. There's no perfect time to say, let's wait for this paper. Some said, let's wait for Cabana and then publish it. But things move so fast, there's no great time. You just got to pick a date and do it. And we kept with a 5-year schedule. Well, this paper is a monster paper. You know, in the final published form, it will be about 160 pages, about 150 references, 10 figures, 10 tables, 60 authors. It's a huge document that really covers every aspect of AF ablation, from mechanisms to techniques to complications to clinical trial design. So it's very, very comprehensive for the entire field. I think the most important things are probably the revised indications. There's sections on revised best practices for how to perform AF ablation, anticoagulation, and there's a totally revised section on clinical trial design, definitions, that sort of thing. Well, I think there's we'll say 5 major differences. One, it's much bigger. It's much broader in terms of the areas we cover. We have a table going on over post-ablation symptoms and when to suspect certain complications, for example. Another aspect of the document, it has probably 2 or 3 times as many references, and every single recommendation we make is referenced. So if you want to say, why did they recommend X, Y, or Z, there listed are the 10 or 20 papers that were the basis of that recommendation. But there's big changes on indications. If you ask me, the single most, I think, interesting or important aspect of the paper, or what I think it will be known for, is it's the first document to recommend catheter ablation in patients with asymptomatic atrial fibrillation. You'll recall in the last 2 documents, we don't even mention asymptomatic AFib. We don't say you should do ablation or you should not do ablation. We remain silent. And in this document, the writing group felt it was time to step forward and address this important issue, and it gives it a 2B recommendation for paroxysmal or persistent AFib in select patients after a careful discussion of risk, benefits, and alternatives. The other thing, which is a small detail, is when you look at the indications figure, you won't see asymptomatic AFib mentioned. It's only in the table, it's only in the text, and that's because we don't want to encourage everyone to start ablating asymptomatic AFib, you know, right, left, and center, but to be very thoughtful, very considerate, very selective. But we do think there's a basis for it, and I know I've performed ablation in asymptomatic AFib, and if I had asymptomatic AFib, I would want it ablated. Well, I think ablation is front and center. It's growing rapidly. I mean, if you look all over the world, whether it's China or Korea or Japan or the US or throughout Europe, catheter ablation is booming. I mean, more and more procedures performed at every major center, new centers popping up. And it's growing because it works. No, it's not perfect. It's not a WPW ablation. We have room to improve, but it does work. It works a lot better than drugs, and it works in many populations of patients. Let me also say, in the indication section of this document, we provide indications for AF ablation in the elderly, and those with heart failure, those with hypertrophic cardiomyopathy. In Tachy-Brady syndrome, instead of putting in a pacemaker, putting a patient on an antiarrhythmic drug, you can do ablation. That's an indication for the procedure. So it's growing rapidly. We have more work to do, but it's the best we got. Well, we need more research on I mean, if you say what are our 2 biggest challenges, I think one huge challenge is we need the single procedure success rate in optimal candidates to go up from 60 or 70 or whatever percent to 80 or 90%. So I think that's going to happen with better technologies, better understanding of how to deliver RF energy, how to create the biggest, most, the best optimal lesion. So I think we're incrementally getting there, trying to get that single procedure success rate up in the optimal patient. And then we need to know what to do with a persistent patient. You know, there's 10 different ablation strategies that have been proposed. The STAR AF2 study blew most of them up, and we have to sort of start from scratch. But we have to remember the importance of well-controlled, randomized clinical trials before we widely embrace something like cafe ablation, which turned out to be really the wrong strategy.